Intestinal resection and anastomosis is a common procedure performed in order to remove non-viable or diseased intestines with a dehiscence rate between 3 and 28%. Anastomoses in small animals are commonly performed with either a traditional hand-sewn technique or surgical stapling device. While surgical staplers have many purported benefits over hand-sewn anastomoses, including decreased tissue handling, ease of addressing luminal disparity, a reduced inflammatory response, and a faster surgical time, their use is limited in application due to their fixed staple heights. The stapling devices and sizes presently used in veterinary medicine have been adopted from human medicine without any formal investigation into differences in intestinal thickness and vascularity. Blue staples with a closed height of 1.5 millimeters are most commonly used in veterinary medicine, with reservation of green staples with a closed height of 2 millimeters for gastric surgery. While this may be fitting for human intestines with a mean thickness of 1.5 millimeters, canine intestinal thickness ranges between 2.06 and 3.13 millimeters histologically. Thus, larger staple sizes may be indicated. There's a lack of data in the veterinary literature comparing the resistance to leakage for small intestinal anastomosis techniques in the face of varying staple sizes and modifications of the traditional GIA-TA functional end-to-end stapled anastomosis, or FISA. These modifications include use of a GIA stapler for the transverse staple line, which eliminates the need to utilize more than one stapler type, or oversewing of the TA staple line, which facilitates tissue inversion. Additionally, the literature is lacking data evaluating gross canine intestinal thickness at each of the anatomical divisions. The primary aim of this study was to compare hand-sewn and 5 stapled anastomosis techniques via intraluminal pressure testing and time to construct completion. The second aim of the study was to obtain further information regarding canine gastrointestinal thickness that may aid in formulation of guidelines for staple use in veterinary medicine. We hypothesized that oversewn FISAs would have higher leak pressures than traditional FISAs, and that all FISAs would have higher leak pressures than hand-sewn and skin-stapled anastomoses. Our second hypothesis was that a traditional FISA would result in a faster surgical time compared to oversewn FISAs, hand-sewn, and skin-stapled techniques. Our third hypothesis was that the canine gastrointestinal tract would be thicker than that of human intestines. This study was approved by the IACUC of the University of Florida. The grossly normal gastrointestinal tracts of 10 canine cadavers were harvested within 6 hours of euthanasia, and measures of gastric and intestinal thickness were immediately obtained. The jejunum of each cadaver was segmented into 14 8-centimeter long segments and stored at 4 degrees Celsius until construct assembly within 24 hours of harvest. 2 segments from each cadaver were allocated to a control group, which did not receive an anastomosis, in each of the 6 treatment groups, including hand-sewn anastomoses using a 4-up biasin in a simple continuous pattern, a FISA using a blue TA staple cartridge for the transverse staple line, a FISA using a green TA staple cartridge for the transverse staple line, a FISA using a blue GIA staple cartridge for the transverse staple line, a FISA using a blue TA staple cartridge with a Cushing oversew at the transverse staple line, and skin staples with a closed height of 3.9 millimeters, augmented with simple interrupted sutures as described by Kuhlman in 2000. Thus, since 10 cadavers were used, the control groups contained 20 segments, and each treatment group contained 20 segments, with 2 segments comprising each anastomosis, giving rise to 10 anastomoses per group. The time to construct each anastomosis was recorded, and all staple constructs were evaluated with fluoroscopy for proper staple conformation. All controls in anastomotic constructs were leak tested within 2 hours of construct assembly. Each end of the construct was occluded, and an adjacent intraluminal 18-gauge IV catheter was attached to either a pressure transducer or an IV fluid line void of air, as demonstrated in this image. Saline dyed with methylene blue was then infused into the lumen at a rate of 999 mils per hour. The pressure and location at which gross dye leakage from the anastomosis was first observed was recorded as the initial leak pressure. Saline infusion continued until the intraluminal pressure plateaued for 5 seconds, exceeded the maximum pressure of the sensor system, or abruptly declined secondary to catastrophic failure of the anastomosis. The plateau pressure, or highest intraluminal pressure, prior to decline was recorded as the maximum intraluminal pressure. A pre-study power analysis was performed, and a sample size of more than 5 constructs per group was necessary to detect a difference with a power of 90% and alpha of 0.05. Descriptive statistics were used to describe the distribution of initial leak pressures, maximum intraluminal pressures, and time to construct assembly for each anastomosis technique, as well as the distribution of stomach, duodenal, jejunal, and ileal mural thickness among all cadavers. All comparisons of these variables between anastomotic groups and cadavers was performed using the Kruskal-Wallis test with post-hoc analysis using the Steele-Dwas method if significant. For all box plots displayed here and in subsequent slides, the quantitative variable of interest is displayed on the y-axis, while the treatment groups are displayed on the x-axis. Each box represents the 25th to 75th percentiles, the horizontal line is the median, and the whiskers represent the range. Any circles or asterisks indicate potential or extreme outliers, respectively. The cadavers did not differ from each other with regards to gastric or intestinal thickness. When comparing the different anatomical divisions of the gastrointestinal tract, the stomach was significantly thicker than the duodenum, jejunum, and ileum, with a p-value of 0.001. However, the thickness did not differ among the duodenum, jejunum, or ileum, with a p-value of greater than 0.28. For time to construct completion, all anastomoses incorporating suture took significantly longer to complete than staple-only constructs, with a p-value of 0.002. This includes hand-sewn anastomoses, which took the longest to complete, followed by FISA oversew and then skin-stapled constructs. There was no difference in time to completion between the staple-only constructs, with p-values of greater than 0.06. The initial leak pressure was significantly greater for the control group at 308 millimeters of mercury when compared to all anastomosis groups, with a p-value of less than 0.001. However, there was no difference in the initial leak pressure between the anastomosis groups, with p-values greater than 0.24. This chart displays the location of initial leakage for all anastomotic constructs. When focusing on the FISA-only constructs, there is a fairly even distribution of leakage from the crotch, the transverse staple line only, the vertical GIA staple line only, and simultaneous leakage from the vertical and transverse staple lines. Similar to the initial leak pressures, the maximum intraluminal pressure was significantly greater for the control group at 430 millimeters of mercury when compared to all anastomosis groups, with a p-value of 0.002. However, there was no difference in the maximum intraluminal pressure between the anastomosis groups, with p-values greater than 0.17. Staple conformation was appropriate for all FISA TA green and skin staple constructs. However, 2 of the FISA TA blue 2 of the FISA oversew and 1 of the FISA GIA constructs had a single non-compressed staple in the transverse staple line, as indicated in this image by the arrow. All vertical GIA staples adopted a normal conformation. An ex vivo canine model was used in this study to compare leak pressures and construct completion time of 6 intestinal anastomosis techniques, as well as to define the normal canine gastrointestinal thickness. Contrary to our first hypothesis, all anastomoses had a similar initial leak pressure and maximum intraluminal pressure, which exceeded the reported maximum physiologic peristaltic pressure of 25 millimeters of mercury. This suggests that all 6 anastomotic constructs may be considered when performing a small intestinal anastomosis. While all 6 constructs may be considered based on the resistance to leakage alone, consideration of intestinal thickness, leakage location, and time to construct completion support preferential use of some techniques over others. First, in accordance with our hypothesis, the mean mural thickness of the canine intestine was consistently 1.6 times greater than that of humans and the closed height of blue staples. Thus, the larger green TA staple size may be most appropriate for intestinal use in dogs, especially when considering that the mural wall thickness is doubled when the stapling device is placed around both luminal walls. Use of a more appropriate staple size may reduce the dehiscence rate of stapled anastomoses by minimizing compromise of the intestinal microvasculature secondary to a fixed staple height. Second, the study suggested that oversewing of the transverse staple line may aid in mitigating dehiscence, as leakage from the transverse staple line was observed in 50% of non-oversewn FISAs, but only 20% of oversewn FISAs. However, while the time to complete oversew constructs was half that of the hand-sewn anastomoses, when the oversew constructs are compared to the staple-only FISAs, the addition of suture oversew prolonged the time to completion by 5-fold. Thus, constructs utilizing solely staples may be favored in unstable patients. The major limitation of this study is its ex vivo nature, which may not resemble construct performance in vivo. Cadaveric tissue may behave differently than live intestinal tissue with regard to compliance and tissue deformation, and precludes evaluation of vascularity. Additionally, leak testing solely evaluates the anastomotic repair under tension and cannot be used as a direct predictor of dehiscence. In conclusion, all 6 anastomotic constructs may be considered when performing a small intestinal anastomosis. However, techniques incorporating suture significantly prolong surgical time when compared to staple-only techniques. The greater intestinal mural thickness in dogs may warrant use of a larger staple size, supported by a lack of serosal tearing and appropriate staple conformation for all FISA TA green constructs. While utilization of green staples may not have biomechanical advantages ex vivo, it may have a significant influence on anastomotic health in vivo through preservation of blood supply to the anastomotic edges due to a less restrictive staple height. Thus, a comparative analysis of the effect of blue and green staple sizes on intestinal microvasculature is warranted. I would like to thank the Society of Veterinary Soft Tissue Surgery for allowing me to present my research today, as well as my mentor, Dr. Penny Regier, for all of her support and encouragement in completion of this study. At this time, I would like to take any questions. Thank you. Intraoperative leak testing has long been a common practice in veterinary medicine. While leak testing is unable to predict the effect of clinical risk factors on intestinal healing, it provides a means of evaluating the integrity of the surgical repair and has been validated as a means of reducing postoperative leakage in human surgery, as well as serving as a valuable tool for surgeons in training. Unfortunately, few studies evaluating leak testing in veterinary medicine exist, with all presently available data evaluating intestinal punch biopsies. Specifically, Sale in 2010 concluded that infusion of 16 to 19 milliliters of saline into the lumen of a digitally occluded 10 centimeter jejunal segment generated the maximum physiologic peristaltic pressure of 25 millimeters of mercury that was previously defined by Tasaka in 1976. In 2014, MATS expanded upon Sale's study to conclude that the saline infusion volume to generate an intraluminal pressure of 25 millimeters of mercury did not differ between longitudinally and transversely closed enteric biopsies. Most recently, in 2019, Brand established that use of a 22 gauge needle for saline infusion into 10 centimeters of intestine minimized leakage from the injection site in porcine small intestine. Unlike intestinal biopsies and enterotomies, anastomoses are inherently more complex and present greater opportunities for surgeon error that may be mitigated with leak testing. Additionally, the circumferential repair may preclude identification of leakage from intraluminal saline infusion alone, demanding a different method of leak testing for it to be of clinical value. In human colorectal surgery, intraluminal air insufflation is performed rather than saline infusion. While air insufflation has reduced postoperative leakage by as much as 77% in humans, the use of saline in dogs prevents translation of this conclusion that leak testing is of clinical value. The objective of this study was to compare the rate of postoperative dehiscence among hand-sewn and stapled intestinal anastomoses with a positive, negative, or no intraoperative leak test in dogs. We hypothesized that hand-sewn small intestinal anastomoses would be more likely to undergo intraoperative leak testing than stapled anastomoses, but that there would be no difference in dehiscence between hand-sewn and stapled anastomoses, anastomoses that were and were not leak tested, and between anastomoses with a positive or negative intraoperative leak test. All dogs receiving a hand-sewn or stapled anastomosis at the University of Florida between 2008 and 2019 were identified in the medical records database. Dogs were excluded if a colocolic anastomosis was performed, the duration of follow-up was less than 5 days, or if perioperative death occurred unrelated to dehiscence. Data was collected regarding signalment, indication, preoperative factors, anastomotic location, surgical technique, intraoperative leak testing, postoperative dehiscence, and duration of follow-up. Surgical indication, presence of preoperative septic peritonitis, anastomotic reinforcement, and dehiscence were compared between stapled and hand-sewn anastomoses, anastomoses that were and were not leak tested, and anastomoses with a positive or negative leak test using Fisher's exact test. Contrarily, albumin was compared using the Mann-Whitney U test. Statistical significance was set at a p-value of less than 0.05. In total, 131 dogs met the inclusion criteria, with a total of 144 small intestinal anastomoses performed. 94 or 65% of the anastomoses were functional end-to-end stapled anastomoses or FISAs, while 50 or 35% were hand-sewn. Mixed breed dogs were the most common breed, with a median age of 5.7 years in the FISA group and 6 years in the hand-sewn group. The most common indication for resection in both groups was a mass. Preoperative serum albumin was measured in 65% of dogs, with a mean of 2.63 grams per deciliter in the FISA group and 2.2 grams per deciliter in the hand-sewn group, which did not differ between these groups, with a p-value of 0.84. Preoperative septic peritonitis was present in 38% of dogs, the incidence of which did not differ between the FISA and hand-sewn groups, with a p-value of 1. Finally, 74% of anastomoses were reinforced with omental or serosal wrapping, the incidence of which did not differ between FISA and hand-sewn groups, with a p-value of 0.75. Of the 144 anastomoses performed, 62 were leak tested intraoperatively. Specifically, 36 of these were hand-sewn and 26 were FISAs. Thus, 72% of the hand-sewn anastomoses and 28% of the FISAs were leak tested intraoperatively, which was significantly different with a p-value of less than 0.01. Of the 62 anastomoses leak tested, 5 were positive for leakage, while the remaining 57 had a negative intraoperative leak test. 3 of the 5 positive tests occurred in FISAs, while the remaining 2 were hand-sewn anastomoses. Thus, 11.5% of FISAs and 5.5% of hand-sewn anastomoses had a positive leak test, which was not statistically different with a p-value of 0.64. All anastomoses with a positive leak test were reinforced with simple interrupted sutures until no leakage was observed. 13 of the 144 anastomoses dehisced postoperatively at a median of 4 days. 10 of these were FISAs and 3 were hand-sewn. Thus, 10.6% of all FISAs and 6% of all hand-sewn anastomoses dehisced postoperatively. The incidence of postoperative dehiscence was not different between stapled and hand-sewn anastomoses, with a p-value of 0.54. Of the 13 anastomoses that dehisced, 5 were leak tested intraoperatively, while 8 were not. Thus, postoperative dehiscence occurred in 5 or 8.1% of anastomoses that were leak tested, and 8 or 9.8% of anastomoses that were not. The incidence of postoperative dehiscence was not different between tested and untested anastomoses, with a p-value of 0.78. Of the 13 anastomoses that dehisced, 0 had a positive leak test, 5 had a negative leak test, and 8 were not tested. Thus, postoperative dehiscence occurred in 0% of anastomoses with a positive test, 8.8% of anastomoses with a negative test, and 9.8% of untested anastomoses. There was no difference in dehiscence among positive and negative leak tests, with a p-value of 1. Overall, this study fails to establish an association between intraoperative leak testing and a reduction in the incidence of postoperative dehiscence in dogs undergoing stapled or hand-sewn small intestinal anastomoses. All hypotheses were accepted, as hand-sewn anastomoses were more likely to undergo intraoperative leak testing, and there was no difference in dehiscence between hand-sewn and stapled anastomoses, anastomoses that were or were not leak tested, or anastomoses with a positive or negative leak test. While this contradicts the human literature, it's imperative to understand that leak testing aims to achieve average physiologic peristaltic pressures, solely evaluating the strength of the surgical repair. This emulates the inflammatory phase of healing, where anastomotic integrity is dependent on the suture or staple line. It fails to consider preoperative, other intraoperative, patient-dependent, and intestine-dependent factors that can also contribute to dehiscence. Ultimately, the multifactorial nature of dehiscence and inherent limitations of leak testing complicate interpretation of the results of this study. Most importantly, a lack of statistical significance should not make intraoperative leak testing obsolete, as it may provide valuable information for improving surgical skill, particularly in novice surgeons. Of note, dehiscence was not observed in any of the anastomoses with a positive leak test, likely due to augmentation of the leakage sites. Contrarily, 8.8% of anastomoses with a negative leak test dehisced. Thus, a positive leak test with subsequent reinforcement may have prevented dehiscence secondary to inadequate surgical technique. Limitations of this study include those inherent to retrospective studies. Data was obtained from operative reports requiring dependence on reporting of leak testing and accurate representation of the intraoperative results. Additionally, low numbers of positive leak tests and dehiscence may have contributed to type 2 error. However, the most significant limitation is a lack of standardization of leak testing. In this study, the length of intestine included and the volume of saline infused varied anywhere between 6 to 20 centimeters and 6 to 20 milliliters, respectively, making it unlikely that a maximum physiologic peristaltic pressure of 25 millimeters of mercury was reached in all anastomoses. In conclusion, this is the first study to evaluate the effect of intraoperative leak testing on reducing anastomotic dehiscence in veterinary medicine. While a positive leak test may reveal poor surgical technique, a negative test does not guarantee that dehiscence will not occur. Given the morbidity and mortality associated with dehiscence, its multifactorial nature, and the potential utility of leak testing in improving surgical technique, leak testing may have greatest clinical utility for novice surgeons in aiding in elimination of poor surgical technique as a factor of dehiscence. Prospective studies to standardize leak testing with adoption of intraluminal pressure monitoring is imperative to elucidate the benefits of leak testing. Moreover, comparative analysis of the sensitivity of saline infusion as presently used in veterinary medicine, and air insufflation as used in human medicine is warranted to determine if one technique is superior for detecting leakage. I would like to thank the Society of Veterinary Soft Tissue Surgery for allowing me to present my research, as well as my mentor, Dr. Penny Regier, for all of her support and encouragement of this retrospective. At this time, I would like to take any questions.
So the introduction, enteral nutrition is an important aspect of improving patient outcomes in hospitalized patients, and nasoenteric tubes, whether it's nasogastric or nasoesophageal tube placement, is commonly utilized in human and veterinary medicine to provide that enteral nutrition. In our hospital, they're used ubiquitously because they're simple, easy, and a cheap way to deliver enteral nutrition. There are, however, various complications which include pneumonia, acute respiratory failure, pneumothorax, and even death, which have been reported in the human medical literature associated with the blind misplacement of nasoenteric tubes in the respiratory tree. Similar complications have been reported in limited numbers within the veterinary literature, but no fatalities have been documented directly due to misplacement of nasoenteric tubes in the tracheobronchial tree. So the aim of this presentation today is twofold. Firstly, I'd like to describe the fatal complications attributed to misplacement of nasogastric tubes in 2 intubated veterinary patients at our hospital. And the second is to review potential options for earlier detection of nasoenteric tube misplacement to reduce the risk of future fatalities. So the first case is an intraoperative placement case. It's an 8-year-old female spayed Shetland sheepdog who presented for a cholecystectomy and partial cystectomy. Surgery was performed with no complications, and the nasogastric tube was placement was attempted when the celiotomy incision was open following the completion of the surgeries. When the tube was advanced, there was resistance met, and the surgeon couldn't palpate the NG tube at the lower esophageal sphincter. So at that point, the NG tube was removed. And following that removal, the surgeon noted that there was ballooning of the diaphragm. And so to relieve the intrathoracic pressure of the diaphragm, to relieve the intrathoracic pressure, the diaphragm was incised. The surgeon noted upon incision of the diaphragm that they could smell the isoflurane. So a red rubber catheter was placed and the diaphragm was closed, but negative pressure wasn't achieved, so a thoracostomy tube was placed with continuous suction. Despite this, however, the patient became apneic and arrested. The second case is a post-operative placement case that I'll be presenting to you. And this was a 9-year-old male neutered Pomeranian who presented for exploratory laparotomy, including a partial pancreatectomy, splenectomy, cholecystectomy, and cystotomy. The surgery was performed with no complications, and the NG tube was placed under general anesthesia in recovery to facilitate proper enteral nutrition due to the extensiveness of the surgical procedures that were performed on this dog. Immediately following placement, a left lateral radiograph of the neck and thorax were obtained. And so here you can see the left lateral radiograph taken of our patient, and the initial interpretation from the radiologist was that the NG tube was passing through the esophagus and down further into the alimentary tract. And the little asterisk on the screen is just to denote the NG tube. So day 1 post-op, NG tube feeding was started on a CRI, and 36 hours following that start of feeding, the patient became dyspneic and had abdominal distension. So at this time, the NG tube was aspirated, and 40 milliliters of pink-tinged fluid was removed. 4 hours following that, the patient's condition deteriorated further, and a point-of-care ultrasound was performed, which revealed mild pleural effusion bilaterally, which prompted the clinicians on this case to request orthogonal thoracic radiographs. And so these are the two view radiographs that were taken following the ultrasound. And while the original left lateral radiograph may have had the appearance that the NG tube was correctly placed, these views help to clearly differentiate that the NG tube was actually misplaced in the tracheobronchial tree. And you can see in this view that the patient had moderate pneumohydrothorax, as well as a presumptive secondary right caudal lung lobe perforation and isocalothorax. So after reviewing the radiographs, the patient had bilateral thoracostomy tubes placed, and that was followed by the removal of the NG tube, which led to a subsequent continuous pneumothorax, but that was managed with vacuum-assisted drainage of the thoracostomy tubes. However, 4 days after initial presentation, the patient arrested and CPR was attempted, but it was discontinued at the owner's request. So in terms of case discussion for the two cases, so one of the big points is that NG tubes are commonly used due to their low cost and efficiency, the fatality rate at our institution is less than 1%. But the big point here is that these fatalities are preventable, and they're still significant because had other safety measures been in place, they wouldn't have occurred. So one of the big takeaways is that in the first case, there was an acute pneumothorax that developed that was due to removing the NG tube, which led to a subsequent defect in the lung parenchyma, and that was done before placing the thoracostomy tube. So in the second case, one of the most critical points that was taken away was in managing this case was placing the thoracostomy tubes before removing the NG tube to try and prevent that development of a pneumothorax. And that was successful and not thought to be the cause of death, although it cannot be entirely ruled out. In the second case, the post-operative placement case, it's thought that the inflammation secondary to the isocalothorax likely induced pleuritis and pneumonitis, which probably contributed to the acute respiratory distress syndrome and ultimate CPA. So the big myth. There's a popularly regarded myth that the presence of a cuffed endotracheal tube makes it virtually impossible to misplace the NG tube into the respiratory tract. But contrary to popular belief, in human medical studies, it's been reported that mechanical ventilation and intubation actually increase the risk of nasoenteric tube placement. There was a large review of over 9,000 nasoenteric tubes that were blindly placed in humans, and 60% of tracheobronchial misplacements actually occurred in mechanically ventilated patients. And they talked about the reasons for the high rates of misplacements and thought that it was due to a combination of factors, which they listed included altered mentation, lack of gag reflex, presence of an ET tube preventing normal glottic closure, and inhibited swallowing. So moving away from the current standard in our hospital was a properly taken and interpreted lateral radiograph of the neck and thorax after blind placement of an NG tube. And so the first change that we've implemented in our hospital is requiring 2-view orthogonal radiographs in the absence of direct intraoperative palpation of the tube in the stomach. And so the tube use just allows for a more accurate triangulation of the nasoenteric tube and better confirmation of the location to kind of prevent what occurred in case 2, where initially they'd only taken the lateral radiograph and it appeared as though the nasogastric tube was actually in the esophagus when in fact it was in the trachea. Additionally, there's also a no feeds before 2 reads rule, where the radiographs must be reviewed by 2 radiologists before you can begin feeding through the NG tube. And while the first change that was implemented is useful at detecting misplaced NG tubes, this is performed when the tube is fully advanced, and it can only identify the misplacement after it's occurred rather than prevent the potentially devastating complications. So to try and prevent this complication, another required change that our hospital has implemented is that in anesthetized patients, there must be direct visual confirmation of NG tube placement within the esophagus rather than the rim of glottis prior to being fully advanced into the stomach. And this is done with the use of a laryngoscope, just visually ensuring that the NG tube is not passing through the rim of glottis. Now, there are some other early detection methods that should definitely be touched upon. One of them is this 2 checkpoint insertion. So the concept behind this method is that you aspirate the NG tube for negative pressure, and it's performed at certain anatomical landmarks before being fully inserted to the distal endpoint of the NG tube to try and mitigate any trauma if the NG tube is misplaced. So for this technique, if the tube is correctly placed in the esophagus, when you aspirate it, there should be negative pressure. And if it's incorrectly placed, when you aspirate it, will be continuous suction, and it would let you know that the NG tube is not in the esophagus and you should try and reposition that NG tube. The effectiveness of this method is yet to be prospectively studied. However, it's also important to note that 2 previous case reports noted negative pressure in the respiratory tree, presumably due to the tube lying against a tracheal wall or wedged into a bronchus. Another early detection method is the use of capnography, which utilizes physiological distinctions in carbon dioxide concentrations in the respiratory tree versus the esophagus. And so for this method, if the NG tube is correctly placed, you should have a capnographic waveform present initially when you're inserting the NG tube through the upper respiratory tract, but it should be absent once the tube is inserted into the esophagus and further into the alimentary tract. And then how you can tell if the NG tube is incorrectly placed using this method is that you see that initial capnographic waveform as you enter the upper respiratory tract, but instead of them disappearing they would remain throughout the entire insertion, far beyond the point when you would think that the NG tube would be in the esophagus. And so this method has been validated in healthy dogs, but it hasn't been utilized clinically. And a clinical study is currently underway in our hospital to validate its clinical use. In a pilot study that we've run, so far this test has been 100% sensitive. And so here is just a short video of the capnography demonstration. So this is the CO2 portion of the screen, and so here you start to see the waveform. So at this point, the NG tube is in the upper respiratory tract being passed through the nares, and once you see the line flatten at this point here is when you know that the NG tube has actually entered the esophagus, and you see the disappearance of that waveform. And so if the NG tube had actually been misplaced in this video, what you would have seen is that instead of the capnographic waveforms doing this flat line, it would actually continue, and that would prompt you to think that potentially that the NG tube was in the trachea or further down in the respiratory tract. So in conclusion, enteral nutrition is a critical pillar of patient care that helps facilitate healing. And nasoenteric tubes are commonly used in veterinary medicine, and while they're both cost-effective and facilitate easier administration of nutrients, they are not risk-free. And so I hope this case report helps to sort of demonstrate that although it's uncommon, deaths as a result of NG tube misplacements into the tracheobronchial tree do occur in veterinary patients, but the risk can be mitigated with a few simple changes to standard operating procedures. I hope you enjoyed my presentation. Thank you so much for your time. I'll take any questions or comments.
And this is about a cat that did not read the book, unlike this picture. So this was a 10-year-old male, neuter, domestic short-hair indoor cat that presented to ER. The cat was from a multi-cat household, presented to ER for acute onset of abdominal distension. Owner noted the abdominal distension on the day of presentation, and the cat was reportedly otherwise normal appetite, doing well, some diarrhea occasionally, but otherwise acting normally. After getting some history and physical exam, it was noted that this cat, 4 months prior to presentation, was diagnosed with intestinal thickening, lymphadenopathy, and splenic changes by an RDBM ultrasound. They recommended starting prednisolone and Serenia, and the pet was doing fine on those medications for 4 months, just having some occasional diarrhea. This pet presented to an internal medicine specialist a month prior to presenting to ER for just a second opinion and follow-up and management on the diarrhea. The physical exam at that point was unremarkable, except some palpable mid-abdominal mass. So an abdominal ultrasound was recommended by the internist, which findings were a small intestinal mass, severe mesenteric lymphadenopathy, and some trace ascites. At that point, there was a large lymph node that was sampled with ultrasound guidance, and FNA was obtained and came back as mild to moderate eosinophilic lymphadenitis. Pathologists commented that due to the clinical history, an eosinophilic lymphadenitis secondary to lymphoma should be considered in this patient. These are some ultrasound images from the internist. You can see there's a very large abdominal lymph node that's about 4.5 by 4 centimeters. This is the intestinal mass, which was a suspected tumor mass that's about 2.5 centimeters. And this is the picture of the intestinal thickening that they found on sound. Based on the FNA results, the internist recommended surgical explore and biopsy, but owner declined. This owner was not interested in putting the cat under anesthesia and surgery. The other option that was recommended to the owner was an ultrasound-guided TrueCut biopsy of the lymph node to get a bigger sample, which owner approved. So a week after the initial FNA and ultrasound, cat represented to the internist, and they put the cat under some anesthesia and got a TrueCut biopsy. At this point, the cat was still doing well, eating fine, just having some diarrhea. They got the ultrasound guided biopsy results with the TrueCut, and it came back as round cell tumors with eosinophils. So the pathologist recommended running some staining tests to rule out mast cell tumor, and the tests were run and it came back negative. So at that point, the pathologist commented that a small size, low grade lymphoma is the most likely diagnosis for this pet. At that point, a CBC chemistry was performed, which showed some mild hypernatremia with sodium of 160, mild leukocytosis, and moderate anemia. Hematocrit was 24% for this pet. At that point, the internist recommended an oncology consultation, told the owner that it's probably small cell lymphoma, go see an oncologist. The owner took the pet to an oncologist 2 weeks after the initial ultrasound by the internist, while the pet was still doing well, just having a little bit of diarrhea. Oncologists discussed surgical biopsy and potentially removing the mass with resection anastomosis and follow-up chemotherapy once a confirmed diagnosis of the mass itself is achieved, because this was just the biopsy of the lymph node so far. The internist was worried biopsying the mass might cause rupture of the intestine and septic peritonitis. That's why the mass was not biopsied. The other option that the owner was more willing to pursue was just starting chemotherapy for intestinal small cell lymphoma, given the lymph node biopsy results being very suspicious for small cell lymphoma. Owner elected chemotherapy options because she was not interested in pursuing surgical options at that point. So CCNU was started on this pet along with the prednisolone and Serenia. 2 weeks after starting the CCNU, owner took the pet to local ER due to pet having acute abdominal distension. All of a sudden, one day she noticed that the abdomen is distended. Pet was still eating well, seemed comfortable, otherwise doing fine. The ER clinic the local ER clinic, took some x-rays, abdominal x-rays, which I have the images, and they diagnosed the pet with septic peritonitis due to pneumoperitoneum and recommended immediate surgical intervention. These are the local ER x-rays. As you can see, there is pneumoperitoneum and there's this mass effect in the mid-abdomen area. This is the VD view that shows the extent of pneumoperitoneum. So there's a lot of gas in this cat's abdomen. Owner at that point took the pet home, did not want to consider surgery. So presented to our ER 24 hours after pet having this abdominal distension and being diagnosed with pneumoperitoneum. A repeat CBC chemistry was performed at our ER, which was very similar to the one that was done 2 weeks ago with the oncologist. Mild neutrophilia and moderate anemia with the PCV of 24%. Our ER doctor also recommended emergency abdominal explore. Owner declined again. The other option that was recommended was humane euthanasia. Owner declined that option as well and decided to just take the pet home. Interestingly, owner finally made an appointment with the surgery department 4 days after diagnosis of pneumoperitoneum. So pet comes to see a surgeon 4 days after having a confirmed diagnosis of pneumoperitoneum and having progressive distension of the abdomen. At that point, we repeated abdominal ultrasound, which showed severe amount of free abdominal air, severe mesenteric lymphadenopathy, and trace ascites. A repeat CBC chemistry was performed and was very similar to the ones before. So mild leukocytosis, moderate anemia. At this point, pet was still eating well, comfortable, just having distended abdomen. So finally, 5 days after diagnosis of pneumoperitoneum, we took this pet to abdominal explore surgery. I wish I had a video of this. This was pretty interesting. As we made the stab incision into the linea, gas just evacuated from the abdomen and you could hear the abdomen deflate. Findings in the surgery were some trace free abdominal fluid. There was a very large non-resectable mass involving basically the entire jejunum. It was about 24 centimeters and it was connected to the root of the mesentery too. There was a gastric mass, there was duodenal intramural mass, there was thickened and abnormal looking mesentery and small intestines all over. So at that point, the concern for this pet was carcinomatosis. We called the owner intra-op and explained all of the findings, and she decided to just get biopsies and not try to remove the mass or anything, just get biopsies and close the pet. So that's what we did. We got the entire GI tract was submerged in saline. So we filled the abdomen with saline to find the source of that leakage of air, but we were unable to find any obvious source of leakage. We did a partial gastrectomy and removed that mass in the stomach. We did multiple fine needle aspirates of the jejunal mass, and we got a 4 millimeter biopsy of a mesenteric thickening under the jejunal mass. On top of that, we got some of the abnormal looking omentum as a biopsy and placed the JP drain in this pet. Pet recovered uneventfully from the surgery, did well overnight. The next morning was really comfortable and already eating. The JP drain started producing some chylous looking fluid, kind of like a whitish chylous looking fluid. We did drain cytology on it. There was no evidence of bacteria. There were only a few lymphocytes in that cytology the next day. Cat's PCV remained stable at around 25%. After surgery, the abdominal distension resolved. We also sent out some blood and drain fluid cytology comparison to find out what that chylous looking fluid is, and it was confirmed as being a pseudochylous effusion. It was not a true chylous effusion. 4 days after hospitalization, the drain fluid started clearing up and the production of fluid slowed down. So Cat continued to eat well in the hospital. The drain was removed 4 days later and went home after 4 days of hospitalization. It's a picture of the chylous-looking fluid from the JP drain. Histopathology results came back, not very helpful necessarily. The jejunal FNA was inconclusive. It came back with just some mixed inflammation. Abdominal fluid was modified transudate. The underlying cause of the effusion was not apparent. Nothing grew on the culture of the abdominal fluid. The only interesting finding was that there was a stomach ulcer. There was a gastric ulcer on that piece of the stomach, which we thought is a mass. Jejunum and mesenteric biopsies came back suggestive of intestinal mesenteric lymphoma. So that was the confirmed diagnosis for this pet at this point. And then the peritoneum sample came back with just some neutrophilic peritonitis. This pet was fine for 10 days, and then owner called, and then day 10 post-op said the cat vomited some food. She started Serenia for the cat at home, and vomiting stopped. She was started back on prednisolone on day 11 after surgery based on the oncologist's recommendation. And sutures were removed 21 days after surgery. Owner was just 1 week late in coming back for suture removal. And then the oncology department restarted CCNU approximately about 26 days post-op. At that point, Pet was doing well and came back for a recheck to oncology, no issues, no complaints. And the abdominal distension had completely resolved. A recheck abdominal ultrasound was performed about 30 days post-op, and findings were small intestinal mass, severe mesenteric lymphadenopathy, and trace ascites, basically the findings that we knew before surgery too. This owner, unfortunately, never followed up with the oncology department and just continued prednisolone for this pet. A phone call was made to the owner about 45 days after the surgery, and cat was doing well, eating, drinking, comfortable, no abdominal distension. Unfortunately, pet was euthanized 75 days, which is 2.5 months after surgery, due to low quality of life. So owner brought the cat back and said cat's not been eating for a couple days and not feeling well. So was put down to and was euthanized. On the discussion part, so this was a spontaneous idiopathic pneumoperitoneum, which is extremely rare in cats. There's only one case report that I could find, and that cat had gastric lymphoma and developed a spontaneous pneumoperitoneum. The exact cause of gastric ulcer in this pet was not diagnosed, but we assume that it's either paraneoplastic or steroid related. The cat was on steroids for about 4 months. The source of air leakage was not identified intra-op. We could not find any obvious hole in any viscous organs or hollow organs, but pneumoperitoneum resolved after surgery for this cat. The diagnosis for this pet was a small cell lymphoma, though according to the oncologist, this was behaving more like a large cell lymphoma, which is quite an interesting fact that the diagnosis was not compatible with the way that this cancer was acting. The exact source of pseudochylous effusion was also not identified in this pet, but it resolved without any specific intervention or treatment. It was just for a few days and then cleared and resolved. So finally, some things to just ponder on and think about. Do we still think that pneumoperitoneum is a surgical emergency in cats? I would say yes, we still probably think that, but what if the owner declines? Do we have to consider euthanasia right away, or there are some cases, such as our case, that we're doing fine for 5 days at least after diagnosis of pneumoperitoneum, they were still eating, drinking, comfortable. This cat was doing well for about 5 days. And sometimes getting a diagnosis is very difficult. Even in surgery, we biopsied everything, we got samples of everything, but still the diagnosis was not how the cancer was acting. This pet had good quality of life for about 2.5 months after diagnosis of non-resectable intestinal mass, which is interesting. The cat was basically managed on CCNU, prednisolone, and Cerenia, and was eating, drinking well until the last couple days that quality of life was low. With that, I'll be happy to take any questions from you guys. I wanted to thank the Soft Tissue Society for coordinating this webinar, and I'll be happy to answer any questions. Thank you.
All right, so hopefully everybody here has a pretty good idea of what a portosystemic shunt is, but just for definition purposes, we define it as a vascular anomaly that establishes direct communication between the portal venous system and systemic circulation. As we know, this can be either congenital or acquired, and acquired portosystemic shunts typically form as a compensatory response, either to portal hypertension or to increased resistance within the portal system. We can see it after shunt attenuation with liver disease, and also with primary hepatic anomalies such as AV fistulas and microvascular dysplasia. Usually these dogs are presenting with a variety of clinical signs. Oftentimes they have a history of neurologic signs such as hepatic encephalopathy, ataxia, behavioral changes, but they can also present with GI signs such as diarrhea and inappetence. We can also see cases sometimes presenting with urinary signs alone, such as straining to urinate, cystic calculi, pollakiuria. And then more specifically related to multiple acquired shunts, we can see ascites, and that has been reported in about 45 to 75% of these cases. With regards to portosystemic shunts, there isn't much variation between acquired and congenital. The clinical pathologic abnormalities are often similar and usually reflect a microcytic hyperchromic anemia, increased liver enzymes, decreased liver synthetic values such as hypoalbuminemia and hypoglycemia, and then we can see elevated ammonia as well as increased pre- and postprandial bile acids. With regards to diagnosis of multiple acquired portosystemic shunts, a lot of times we can make that diagnosis either through direct visualization during laparotomy, and usually you will see multiple tortuous vessels, usually at the level of the kidneys. CTA is definitely making comeback as far as our ability to diagnose multiple acquired shunts, and it is commonly used. And then here at UT, we use transplanted portal scintigraphy pretty often because we have it readily available. And there's several papers that have described, various findings that help identify a multiple acquired shunt compared to a single congenital extrahepatic. A lot of times the most pathognomonic finding is going to be that hepatofugal flow at the cranial margin of the kidneys, and it has been reported to be pretty accurate in diagnosing these cases. There has been also reported, and I think it is used in other institutions, per rectal scintigraphy. Those findings are not as well defined, and it's harder to make a diagnosis because of the poor resolution of image. And so we primarily do transplanic portal scintigraphy and have a good outcome and appropriate diagnosis using that imaging modality. And then I just wanted to say something about ultrasound. I think it's something that is readily available, though there is a lot of user variability, and I think it depends a lot on experience. And so that's something to keep in mind when diagnosing these. And sometimes these cases are not always straightforward and easy to diagnose using ultrasound alone. So treatment for these cases is usually aimed at alleviating clinical signs very similar to treating congenital portosystemic shunts. There's currently no recent literature really suggesting that medical management is beneficial in improving long-term prognosis. And there's no literature right now really even reporting long-term survival in these dogs with multiple acquired shunts or really identifying predisposing factors for a poor outcome. And so our study objectives were, one, to determine long-term outcome and identify predisposing factors that affect the patient's survival, especially those with multiple acquired portosystemic shunts. And we hypothesized that dogs that develop multiple acquired portosystemic shunts, either from previous surgical attenuation or progressive liver disease, will have a poor outcome compared to dogs with secondary multiple acquired portosystemic shunts from congenital abnormalities such as microvascular dysplasia. We also hypothesized that dogs that died of a death related to multiple acquired portosystemic shunts, such as progressive hepatic dysfunction, would have a worse prognosis in comparison to dogs that died unrelated to multiple acquired portosystemic shunts. And so we looked at records at University of Tennessee from January 2000 to August 2018. We included cases that were diagnosed with multiple acquired portosystemic shunts, either based on exploratory laparotomy, transsplenic portal scintigraphy, or CTA. And we also included studies that had information for long-term follow-up within a 24-month period following diagnosis or longer, if applicable. Exclusion criteria: if any of the records were incomplete or didn't have patient history listed, physical exam findings reported, if they mentioned that they had laboratory findings performed, but they were not available for review, or if the patient was diagnosed with multiple acquired portosystemic shunts and there were no recommendations made following that diagnosis. Cases that also were lost to follow-up within that 24-month period were also excluded, and then dogs diagnosed with abdominal ultrasound only were also excluded, just given that user variability that was just mentioned. So when we're reviewing these records, we included signalment, body weight, presenting complaint. We looked at what clinical signs, for how long they were exhibiting these clinical signs, what diet, previous treatments they were on, and how long they were on the treatments. And then if any laboratory abnormalities were noted with the referral paperwork. And then when these patients presented for initial presentation, we looked at physical exam abnormalities, if they had any life-threatening comorbidities, and we also documented the results of in-house diagnostics such as imaging, laboratory work, and histopathology if it was applicable. With the follow-up information, a lot of times we had to obtain records from the primary veterinarian. However, we looked at primarily clinical signs and medical management if they were receiving it at 3 weeks, 3 months, 6 months, 12 months, 18 months, and 24 months following diagnosis. And then we also looked at repeat clinical pathologic analyses for 2 rechecks, and usually that was the first recheck after diagnosis, and then either the second or the final recheck, whichever one was available. And then we also looked at clinical outcome of these cases and whether or not they were still alive or if they had been lost to follow-up. And then we tried to define the cause of multiple acquired portosystemic shunts by identifying whether or not previous shunt attenuation had been performed, whether or not these cases had suggestion of a liver toxin, or if they had a primary liver disease, if these cases had some type of congenital hepatic vascular anomaly such as microvascular dysplasia, or if none of these things were available, then we would categorize these cases as being unknown. So for statistical analysis, logistic regression analysis was used to various criteria with the binary response variable of death-related or likely related to multiple acquired portosystemic shunts. We defined clinical significance as 0.05. We used distribution of survival times using a Kaplan-Meier method. And then Cox proportional hazards model analysis was used to evaluate the cause of multiple acquired portosystemic shunts on survival time with a clinical significance of 0.05. So 113 medical records were reviewed and 72 dogs met the inclusion criteria. We did not see any statistical difference between sex, age, or breed and the likelihood of death. However, we did see that for each additional unit of body weight, there was an 8.2% increase in odds of death. The only factor that was associated with statistical significance prior to presentation was the administration of medical management. And we found that dogs not receiving medical management prior to the presentation to UT actually had a 33.3% decreased odds of death compared to those that were receiving medical management. And then on initial presentation, we also found statistical significance in dogs that were documented without a dull or lethargic mentation. They actually had a decreased odds of death. However, these were not normal dogs. These were comparing dogs with dull or lethargic mentation to dogs that had more severe neurologic signs such as hepatic encephalopathy or ataxia. And so those dogs with more severe mentation changes seemed to have a decreased odds of death based on our data. There was no statistical difference between physical exam findings, comorbidities, initial blood work, or urinalysis with likelihood of death. Diagnosis was primarily made with transplantic portal scintigraphy, followed by exploratory laparotomy and CTA. The most common histopathologic diagnosis was microvascular dysplasia, and that was also the most common cause of multiple acquired portosystemic shunts. It was related to primary hepatic anomaly, followed by shunt attenuation. About 30% of cases were unknown as far as their cause. And then there were no diagnostic imaging findings that showed statistical significance. We did see a fair amount of statistical significance in our recheck blood work. And so these cases that had blood work performed at the first recheck and then either the second or final recheck following diagnosis, those values more specifically were albumin, both at the first and second / final recheck, cholesterol, glucose, and total solids. So for each additional value or each additional unit of these values, there was a decreased odds of death. And you can see the mean value for each of these blood work parameters looking at dogs that had died related to multiple acquired shunts and then dogs that did not. No other blood work findings from these rechecks were statistically associated with death. And so looking at follow-up, about 86% of these cases were alive at 6 months following diagnosis, and about 46% were asymptomatic. 73% of these dogs were alive at 12 months or 1 year following diagnosis, and 72% of those cases were asymptomatic. And about 60% were alive 2 months following diagnosis, and 74% of those dogs were asymptomatic. There was no significant difference found between cause of death and then the median survival time of these dogs that died related to multiple acquired portosystemic shunts was about 580 days. And then dogs that died of a death unrelated to multiple acquired portosystemic shunts had a median survival time of 284 days. And this may have represented, for instance, a dog that was hit by a car. As you can see here in our Kaplan-Meier curve analysis, we have this blue line here that represents dogs that died but did not have a defined cause of death. And so when we were looking at this data, we tried to categorize them. Were they likely, was the death likely related to multiple acquired shunts, or was it unlikely related to multiple acquired shunts? And these dogs that died didn't have any data available, though you can see they had a prolonged survival time compared to those other cases. And so at the conclusion of this study, about 22 of the dogs were still alive. 13 of them were lost to follow-up, but that was after the 24-month period. And then 37 of these dogs died or were euthanized, and this includes the dogs that died likely related to multiple acquired shunts, unlikely related, and dogs that died with no information provided. And then we did not see any significantly different findings between dogs that died with regards to multiple acquired portosystemic shunts and dogs that died of a death unrelated to multiple acquired portosystemic shunts. So that being said, regardless of the cause, there was no increase in odds of death. Therefore, our hypothesis was disproved. That being said, progressive signs of liver dysfunction does seem to have an effect on overall survival time from what we've seen with previous literature. So hypoalbuminemia can result from liver failure as well as hypoglycemia, and it can be used actually as a negative prognostic indicator for liver disease. These findings can also be seen with 70 to 80% of hepatic functional loss. And so we theorize that these findings that were seen on recheck blood work, such as hypoalbuminemia, hypoglycemia, hypocholesterolemia, and hypoproteinemia, were more suggestive of end-stage liver disease, and that's why they were associated with a poor outcome. Also, something to make note of, medical management protocol in these cases did vary. However, it was noted that dogs that were receiving medical management when they first presented did have an increased odds of death. We believe that this is because these dogs are usually more dependent on medical management to manage their clinical signs at home compared to asymptomatic dogs. And that being said, we did not find any specific medication to be associated with the decreased survival. We also made note that dogs with more severe mentation changes like hepatic encephalopathy and ataxia did not have an increased odds of death compared to dogs displaying more mild signs such as lethargy and dullness. And we believe this is largely related to the smaller sample size because we only had 3 cases that were exhibiting more severe neurologic signs versus 11 dogs that were showing signs of lethargy and dullness. Because a lot of times when we think about progressive liver disease, we think of progressive or more severe neurologic signs signs as well, because we usually see hepatic encephalopathy when we lose about 70% of that functional hepatic mass. And so I will also note that these findings weren't really consistent with follow-up, but we didn't necessarily have as much data with regards to follow-up in some of these cases, so it may not be representative. And then another thing to make note of would be the weight of these dogs. So historically, dogs with a smaller weight are more, they usually have a worse outcome. That's not the case in our study. In fact, dogs with a heavier body weight had an increased odds of death. We don't really understand why. We have a couple theories, and the fact that larger dogs seem to be more predisposed to primary liver disease, whereas smaller breeds are more commonly affected by microvascular dysplasia, which usually has a more favorable long-term outcome. Owner compliance may have also played a role. Owners may have been more willing to go forward with euthanasia because of cost of care or trying to take care of a larger breed dog with some of these clinical signs. So our study was a retrospective study, and so that is one of its primary limits. There's a lot of variability in data collection, not necessarily data collection, but medical records, clinician decisions, owner compliance. And I also want to make note that the survival time should be interpreted with care, since there is such a large number of cases lost to follow-up or that died without that information. I will say that the dogs that died of multiple acquired shunts or were defined as being related to it did have a larger sample size, and only about 50% of those dogs were actually alive beyond a year and a half after diagnosis. So ideally, a larger sample size would be great. And then I will say also that some of our numbers might be artificially low because we did exclude cases that were diagnosed with abdominal ultrasound. So in conclusion, dogs with evidence of progressive liver dysfunction and those that were receiving treatment for it were more likely to die. Dogs with smaller body weight may be associated with improved survival. Dogs with more severe signs of hepatic encephalopathy were not suggestive of an increased likelihood of death, but this could very much be related to the small sample size. And dogs that died secondary to multiple acquired shunts did not seem to have a reduced median survival time compared to those that died unrelated to multiple acquired portosystemic shunts. However, these dogs are still unlikely to have a normal lifespan. Those are my references. I just wanted to take a moment to thank Cassie Lux. She's my mentor, and she's been very, very helpful in helping me with my paper and my presentation. Want to thank Folk for helping me with data collection. Sun, who is my very, very patient statistician who has really helped me out, and Dr. Fazio, who has been very patient with me and my imaging questions. And I also wanted to thank the Society of Veterinary Soft Tissue Surgery for allowing me to present my research here today. And with that, I will take any questions.
Portoazygous shunts account for 25% of all congenital extrahepatic portosystemic shunts, and they are unique in that the abnormal communication between the portal system and systemic blood flow occurs within the chest. Typically, it's recommended to attenuate a shunting vessel as close to its insertion into venous return as possible in order to reduce the chances of residual shunting tributaries. Portoazygous shunts have the potential for multiple tributaries from the gastric veins, which are usually located just caudal to the diaphragm. Therefore, ligation of the shunt vessel near its insertion within the thorax may actually lower the risk of persistent shunting-associated consequences postoperatively. Despite its insertion in the thorax, an abdominal approach for attenuation is most commonly reported. Two thoracic approaches have been previously described to attenuate a portoazygous shunt in the thorax near its insertion site into the azygous vein. Harari et al. Described a lateral thoracotomy approach in one case, which, although was successful, did rely on a large incision through the chest wall, transecting of intercostal muscles, and spreading of the ribs, which does create a fair amount of perioperative morbidity in terms of patient comfort and recovery. Although potentially beneficial in terms of avoiding a thoracotomy, the transdiaphragmatic approach to the thorax described by Orr et al. Still relied on a large abdominal incision and an incision through the diaphragm. Additionally, it offered a narrow working space and poor visualization of thoracic structures. There was an inability to fully see the portoazygous shunt at its insertion point, causing the authors to rely on the characteristic L-shaped bend of the shunting vessel to help with placement of the attenuation device. This was made especially difficult if the shunt had a complicated morphology. Though this was not for portoazygous shunts, Miller and Fowler published 2 cases where a laparoscopic approach to the abdomen was used to place cellophane bands around a portosystemic shunt. This laparoscopic approach did allow for visualization of the shunt vessel at its insertion point into the caudal vena cava. However, manipulation of surrounding organs to isolate the shunt vessel was difficult, and it did prolong surgical time. While neither shunt in this report had a portoazygous morphology, the authors did note that portoazygous shunts could be more difficult to isolate from surrounding organs with a laparoscopic approach, especially due to their tendency to traverse through the esophageal hiatus and the need to attenuate the shunt closer to the diaphragm. With these aforementioned studies in mind, we wondered if a thoracoscopic approach towards portoazygous shunts would facilitate improved intra-op visualization, decrease perioperative morbidity, and result in good clinical outcome. Additionally, current literature only describes the placement of commercial portosystemic attenuation devices to occlude shunting vessels within the abdomen, and there is little information on the long-term efficacy to support the use of these devices to attenuate shunts within the thorax. So there is a clinical need to better determine the efficacy of these devices within the thorax. We felt that a thoracoscopic approach to portoazygous shunt attenuation could be a less invasive approach that would provide excellent magnified visualization and allow us to evaluate the long-term outcome when using an amyloid ring constrictor in the thorax. After some cadaveric and laparoscopic trainer practice, we felt comfortable using a thoracoscopic approach for a clinical portoazygous shunt case. So meet Baxter, who is a 1-year-old male castrated Maltese that presented to us for a suspect portosystemic shunt. Baxter had a history of persistently elevated liver enzymes, markedly elevated pre- and postprandial bile acids, and a low protein C at 51%, all of which were concerning for a portosystemic shunt. So he was referred to UF for further workup. We performed a CT angiogram on Baxter to evaluate for the presence of a portosystemic shunt. And if we start caudally at the level of our splenic vein and trace it cranially, we see an aberrant vessel that courses dorsally and then cranially, that then continues forward past the liver and through our diaphragm before inserting into our azygous vein. We also noticed that there was a bulge at the level of the diaphragm with a second aberrant vessel that was contributing to the shunt. And if we traced that second vessel back, we can see that it loops through in the abdomen before tracing it back to the level of our right gastric vein. We also did a 3D reconstruction to try and determine where each aberrant vessel was traveling. So if you imagine the conical shape of the diaphragm overlaying this 3D image, and you line up the hepatic vasculature within the cupula, and then the caudal vena cava traveling through the caval foramen, it does help in visualizing the path of the shunt vessels. So this light white bar represents the level of the esophageal hiatus in relation to the shunt vessels. So you can see that each vessel passed through the hiatus and then they converged together in the thorax, immediately cranial to the diaphragm, before inserting into the azygous vein at the level of T9. So this morphology is what initially interested us in a thoracic approach in order to avoid having to attenuate 2 vessels in the abdomen. And so we elected to try a minimally invasive thoracoscopic approach for placement of an amyloid ring constrictor around the shunt near its insertion point. Baxter was placed in left lateral recumbency in preparation for a right-sided thoracoscopic approach. A 3mm incision was made in the dorsal third of the right 10th intercostal space, followed by blunt dissection into the thoracic cavity with a hemostat. A 3.5mm pediatric cannula was inserted into the incision, followed by a 3.5mm 30-degree scope. Based on CT, we used T9 as a landmark to help with shunt vessel identification, and it was located dorsal to the esophagus and ventrolateral to the aorta within the mediastinum. Instrument cannulas were placed in the 9th and 11th intercostal spaces, roughly 1 centimeter ventral to the instrument port, and the esophagus, vagus nerve, caudal vena cava, aorta, and azygous vein were all identified. The shunt vessel was bluntly dissected from the mediastinum using laparoscopic forceps, as seen in the picture on the left. The caudal instrument portal was removed and the incision was enlarged by another 5 millimeters to allow placement of a 5 millimeter amoroid ring constrictor. The ring was secured to a long piece of 3/0 PDS prior to introduction into the thorax in order to maintain control of the ring in case it slipped out of the instruments. The ring was positioned dorsal to the shunt and rotated downward to capture the shunt vessel within the ring. Once captured, the ring was rotated clockwise until the groove for the key was facing laterally towards the camera. And we originally weren't going to leash the key with suture like we had with the ring, since it could prevent the key from sliding nicely into the ring. However, we did end up losing one key in the thorax, so we decided to leash the second key. And when we were using the laparoscopic training system to practice, we were using 5 millimeter instruments to set the key into place within the ring. However, the size of Baxter required that we use the 3.5 millimeter pediatric set, and we were unable to set the key using those smaller instruments. So we once again removed the caudal portal and then introduced a standard Carmalt into the incision and used the tip to secure the key into place. We were able to secure the tip of the key into the ring and stabilize it with the Carmalts, and then cut the suture off with laparoscopic scissors prior to squeezing it into the ring. Key placement using the Carmalts was successful on the first try, so it is something that we recommend doing. We unfortunately did not record any scope video because we were using a brand new system and the buttons weren't set up yet, which we didn't find out until after. But one student did film this over the shoulder view of some of the manipulation of the ring around the vessel. And so you can see that we're gently rotating the ring around the shunt vessel until the key opening is facing towards us. Baxter recovered uneventfully from surgery with no post-operative IV opioids required. He did receive a pre-op intercostal nerve block, which did help with post-operative comfort level. His chest tube was pulled after 24 hours, and he was discharged home 2 days following surgery. Baxter only required 3 days total of oral pain medications at home before his owner stopped them due to excellent comfort level. Kepper was discontinued after 2 weeks, and there were no neurologic signs noted. And at the 1-month recheck, Baxter had reportedly excellent energy at home, his bile acids had improved, and the protein C had normalized. Amoxicillin was stopped and lactulose was weaned off over the next several weeks. Baxter was weaned off lactulose uneventfully and returned at the end of May for his 5-month post-operative recheck. We had hoped to see him at the 3-month recheck, however, COVID postponed his recheck until May. Baxter had a normal physical exam with no neurologic signs, and his liver values were normal on blood work. His postprandial bile acids were less than 1, and his protein C had improved to 121%. We performed a recheck CT angiogram on Baxter, and you can see that there is no residual shunt blood flow past the level of the amoroid ring constrictor in the thorax. And when you compare the 3D reconstructions from before surgery to 5-month post-op, you can also see that the liver has more vasculature present, which was pretty cool to visualize as well. In conclusion, we were able to successfully place an amoroid ring constrictor around a portoazygous shunt thoracoscopically. The amoroid ring successfully attenuated the portoazygous shunt when placed in the thorax as determined by the CT 5 months post-op. And a thoracoscopic approach facilitated a successful immediate post-operative outcome with minimal morbidity, as well as a successful long-term outcome with complete shunt attenuation. Baxter continues to do well at home and causes lots of mischief. To build on what we've learned from this case, we are now partnering with our colleagues at North Carolina for a prospective study evaluating a thoracoscopic approach for portoazygous shunt attenuation, as well as the long-term attenuation efficacy of an amoroid ring constrictor and thin film banding in the thorax. The study is currently underway, and we hope to present the results at next year's conference. I would like to thank the Society of Veterinary Soft Tissue Surgery for allowing me this opportunity to present Baxter's case, as well as my mentor, Dr. Alex Fox Alvarez, and our radiologist, Dr. Grosso. And of course, a huge thank you to Baxter and his owner, Norma. I'd be happy to take any questions at this time.